My next speaker is Professor Jawad, who is the consultant rheumatologist. And as you know, Suhail has mentioned, he's International Medical Director of Royal College of Physicians. Could you please warmly welcome the chair and the expert?
Thank you very much. Assalamu alaikum. Thank you very much. I will try and be quick because I'm sure you're all hungry. And I mean, certainly one of my daughters, when she is hungry, she becomes aggressive. So, from the hypoglycemia. So I will be quick. In fact, we started with Magdi's excellent introduction and lecture, and in fact, I'll finish on the same theme. By the way, Professor Magdi Yaqub is our specialist advisor on Pakistan at the Royal College of Physicians, and he is the first SPAD. That's his the term SPAD. So he's the first SPAD special advisor. In fact, ministers have SPADs. So there you are, Magdi. Thank you. Anyway, I work with Magdi at the William Harvey Research Institute at Barts and London, but I'm also an NHS consultant, and I'm the Hans Sloan Fellow of the College of Physicians. I have nothing else to declare. This is really, in a way, the aim of this talk is to look at the musculoskeletal manifestations of diabetes and how to diagnose them and how to manage them. And as we have heard, diabetes is extremely common. Millions of people. I mean, I think we work in sub-Saharan Africa, and obviously at the start we used to concentrate on communicable diseases, and now we are working on non-communicable diseases, because again, I think the epidemic has even reached sub-Saharan Africa. Just to remind you that type 2 diabetes is characterized by variable degrees of insulin resistance and deficiency, but type 1 diabetes is an autoimmune disease which leads to the destruction of the insulin-producing beta cells. And there is evidence that type 1 diabetes is increasing at the rate of about 4% a year, certainly in developing countries. And currently 1 in 11 adults have diabetes. In 2040, it's projected that 1 in 10. And as we heard, the law of halves does apply to diabetes as well, and half of the patients who have diabetes do not know that they have diabetes. Sorry. What have I done? Okay, sorry. Maybe just that. And although, as we know that blindness, kidney disease, kidney failure, ischemic heart disease and peripheral vascular disease are really the main causes of morbidity and premature mortality in patients with diabetes. However, it is much less widely known that diabetes is associated with a number of musculoskeletal conditions which occur in those patients more commonly, and it adds to the morbidity. And some of these diseases are really common, are not in a way restricted to diabetes, but very much age-related and smoking-related. However, there are other musculoskeletal problems which are specific for diabetes. So there's a combination of the two. And in addition, some of these conditions arise from the complications of diabetes, such as peripheral neuropathy, while others are really caused by the metabolic abnormality, mainly the glucosylation, which is damaging tissues. I mean, as I said, the problem, although they are rarely life-threatening, but they tend to occur in patients with life-threatening complications of diabetes. And here is listed really the main group, the neuroarthropathy, and I'll mention briefly the relation between rheumatoid and diabetes type 1, gout, RSD, or as is known now, chronic regional pain syndrome type 1, bone fragility, not osteoporosis, but bone fragility, DISH, and then diabetic muscle infarction and the fibrosing syndromes. You could say, what are these fibrosing syndromes? The fibrosing syndromes are 6 frozen shoulder, diabetic frozen shoulder, carpal tunnel syndrome, Dupuytren's contracture, De Quervain's tenosynovitis, the trigger finger, which is flexor tenosynovitis, and the chiroarthropathy, or the limited joint mobility in diabetes. So quickly on diabetic, on neuroarthropathy, you have to remember that if you have a peripheral sensory neuropathy, this would lead to ulcerations, and if there is motor neuropathy, you will get wasting of the intrinsic muscles, so you end up with feet, claw to deformity, and that really adds to producing pressure and maybe to more ulceration. Callus may develop because the arches drop. But the most really significant complication of diabetic neuropathy is Charcot neuropathy. And it was first described by this celebrated Charcot, a Frenchman, who gave details of this condition in patients who suffering with syphilis. But unlike diabetes, syphilis affects the knees mainly, while in diabetes, the main joint affected is the ankle. And the reason for that, it's really because there is disturbance of the sympathetic nervous system, increased blood flow, and there is increased osteoclastic activity and bone fatigue, resorption, and disorganization. And there is a good example for you, and it's usually the ankle, but the MTPJs may be affected, or the mid-tarsal and that distribution, and it's mainly the ankle. And you could see that really it progresses very rapidly. There is bone resorption of the subchondral bone, fragmentation, and ultimately the cartilage will be destroyed, and there will be loose bodies embedded in the synovial tissue, and the bone looked very sclerotic. This is from one of our patients, 67-year-old, with diabetic neuroarthropathy, and you can see the fragmentation, the bone resorption, the disorganization. To remember the features, I'll say the 6 Ds of Charcot, and that is increased bone density, debris, dislocation, disorganization, distension, and destruction. So all the Ds, you can see the arch has fallen, and you can see the amount of bone resorption. And it is quite a serious condition. And it is probably thought that the advanced glycolation end products, what we call age, binding to the receptors, and they seem to be the cause of this. They tend to upregulate the matrix metalloproteinases, which are involved in inflammation. In fact, we have found in lupus that the RAGE products seem to be also the cause of accelerated atherosclerosis in our patients. And management, very difficult indeed. Perhaps the best thing you could do is fit them with a Biloni air cast, because that may reduce the swelling and the edema and keep the patient going. Surgery is best avoided, and there is no point in giving bisphosphonates because they do not work. Now gout, patients with, even if you exclude all confounding factors, type 2 diabetes is more common in gout. Now with rheumatoid arthritis, the association is really very restricted to type 1 diabetes and those who are AC, anti-citrulated peptides, antibody positive, and possibly because they share that allele with these patients. I'm going very quick as well. And this is limited joint mobility is very common. As I will say, they have a positive prayer sign, or as in India I used to say, the positive Hindu greeting sign, and it resembles scleroderma, and in fact it does occur in patients without diabetes. Elderly patients who smoke tend to get this condition, and its incidence is variable. It occurs in type 1 and type 2 diabetes, and as I said, it increases with age and cigarette smoking. And you could also do the sign if you just place the hand on the table, and if it doesn't lie straight, that is also called the positive tabletop signs. And what is the cause? Glucosylation of the collagen fibers, increased in fact, the collagen attracts more water and it becomes less useful. Obviously, reduce the blood supply, the neuropathy and the disuse all adds into the process. The good news is that this condition does improve with time. So, but what you really need, you need to obviously better control of the diabetes, but cessation of smoking, if you could convince them. But stretching is very important. It's one of the few conditions that really does improve with time. Now, the frozen shoulder, the difference between a diabetic frozen shoulder and the classic frozen shoulder, the classic frozen shoulder never occurs before the age of 40. If you see a 25-year-old, and I work in the East End of London, and 30% of our population are of Bengali origin, and 40% develop diabetes by the age of 40. And if I see a patient with a frozen shoulder who is in his 20s or 30s, I check the urine. Every year I find 1 or 2 cases. You diagnose them through a frozen shoulder. The difference between the classic frozen shoulder, the other difference is pain is less an issue in diabetes. It is because it arises the onset is gradual, unlike the classic frozen shoulder. And generally, they don't respond to a steroid injection. What they need to be whacked, stretched. And carpal tunnel syndrome, very common. In diabetics, even in the absence of peripheral sensory neuropathy. And these patients are worth decompressing. The way you diagnose carpal tunnel syndrome is painful pins and needles at night. It's nocturnal pins and needles in the hand. And obviously you could do the Fallon signs and the Tinel sign. Now, trigger finger, again, why do you get trigger finger? Because of the glucosylation of these collagen fibers. And a trigger finger, it's either the finger with a trigger, first thing in the morning more likely, or it can get stuck. It can get stuck in flexion, or it could get stuck in extension. That's all. And generally, these patients do respond to a steroid injection, or that you could decompress them surgically. Dupuytren's contracture is the same. We have but this is now, it's not the deep flexor tendon, but rather the palmar fascia. And luckily now we have a collagenase injections. We inject them locally because the operation is really quite serious, because you have to really cut deep and then do a skin graft in there. So it's common. The Coil veins is similar. The way you diagnose it, usually they present with pain at the base of the thumb. The way to diagnose is the Finkelstein test. You put the thumb inside your hand, make a fist on top of it, and just flex the wrist towards the ulnar side. And you can only do it once because it's very painful. Finkelstein test. Now, the effects on bone, although if you have hyperglycemia, you're going to lose calcium through the urine. But there is a number of differences between type 1 and type 2, but I'm not going to go into a lot of details. But no matter whether you are type 1 or type 2, you have an increased risk of fractures. So really, in a way, the bone density is less important when it comes, but it's the risk of fractures that is important. And there is, although you would expect people who are type 2 diabetes, as my mother would say, I am affluent looking, not fat. She told my wife that I am affluent looking. So anyway, like Steve and maybe Magdi, we're all affluent looking rather than overweight. And you could see that affluent looking doesn't stop you getting, if you are diabetic, from breaking your bones. And you can see the reason for that is because although the bone density may be normal, but in fact there is increased porosity and both cortical and trabecular bone. And this is a very good review for people who want, because that's another lecture. I think it's to look at the pathophysiology of bone fragility in patients with diabetes, because as I said, the DEXA scan does not reflect that. And increasingly, obviously, the falls, the peripheral neuropathy, the poor vision adds in. And remember, with diabetes, is that the thiazolidinediones can also cause increased fracture risk. However, you don't really need to stop people from using them if they need them, because they have osteoporosis. DISH is diffuse idiopathic skeletal hyperostosis. Half of the patients with this condition have diabetes, you have to have 4 consecutive bridging osteophytes on the right side of the dorsal spine, because the pulsating heart on the left side will prevent these bridging osteophytes from happening. And you can see that that's patients with massive, this is not ankylosing spondylitis, this is DISH, diffuse idiopathic skeletal hyperostosis. Another complication which occasionally we see, this is a recent patient, so a couple of months ago, they suddenly get infarction in the muscle, aseptic myonecrosis, and you don't need a biopsy because it shows very well on an MRI scan. But the best thing is to avoid really surgery, and generally, as far as you make the diagnosis, you may have to release the compartment if necessary. There is an increased, in fact, severity of, there is increased evidence that osteoarthritis and symptomatic OA is more common in patients with diabetes. This is a very recent good paper which shows that people are interested. Just to conclude that I've described a number of these musculoskeletal problems. They are easy to diagnose. They are easy to, in fact, some of them are easy to treat and may, in fact, lessen the burden of morbidity in these patients. But obviously, good control of diabetes, stopping smoking, stretching, and keeping as active as possible is the best prevention. Thank you.
We just received a panic call from the lunch people. I want to share that they have 3 minutes before they wrap it up. I'd like to take a few comments, 2 comments from Professor Jawad and Professor Amir Rafour on the talk of Professor Ali Jawad, if I may, please.
Thank you very much for moderating and all the colleagues. It's a wonderful session, a lot of learning for all of us, and especially I think the group from Pakistan and the group from here, very, very appropriate talks, and I'm sure the way forward we have to, the future is very promising for APPS under your leadership and all the colleagues there. And we look forward. I'll suggest that I think APPS, obviously it's in its infancy, but has the right mix to take it forward. Very similar to what APNA is doing, and I have a lot of experience with them. And I think there should be 1 meeting in Pakistan and 1 here, maybe winter there and summer here, something like that. That would help. And the main thing is that all the lectures were of highest standard. Full of the implementation part is always harder, what's the way forward. And I think maybe next year we will have that what we did last year, how much of it has been implemented by whoever can implement. You see, very much actionable points here which we have noted down, and we'll like to collaborate further. Thank you so much.
Thank you, Sohail. I've learned a lesson that you don't comment on affluent people if you're poor like me. So I have, I mean, I won't say much, but this is a joint effort and we look forward to it. I think, privately, because we're running late, but we're desperate that APAS get engaged. I've been in their executive council. Some of you have visited. And I think, as Jawad says, we have seniors who are doyen of medicine like Professor Dawood. It's very easy for you guys to join one of the specialty meetings. We get guests from all over, and that would be the way forward. Thank you very much.
And the last concluding remarks from the chairman, if you may conclude the session for us, please.
Well, I think it's been a good morning. Very quickly, I think it's Captain Kirk or Professor Yaqub really alerted us to to the problems of really chronic disease. And as I said, the impact of chronic diseases is increasing, even in places that are really in very developing. I mean, some of the countries, the total number of physicians in, for example, East, Central, and Southern Africa, excluding South Africa, is around 900 physicians. There are only 900 physicians. The whole of Zanzibar has one physician, for example. But even in these diseases, in these countries, we're seeing increasing hypertension, diabetes, ischemic heart disease, and so on. And people are dying less of infectious diseases. And I think Captain Crump, rather than Captain, he's done really excellent work. He has visited Pakistan so many times that he has eroded my budget, and I had to find extra money to keep sending him. And he has really spent time in villages, in rural areas, and he doesn't really just go and see the bosses, but he has worked with local people. So I think, thank you, Steve, for all your hard work. And Liz is, in fact, she's an expert in evidence-based medicine, and she's been working at the college for a long time, and she's now concentrating on patient safety with Mike Durkin, and it is really important. The principles of patient safety is to be transparent. If something goes wrong, tell patients that they have gone wrong. They are less likely to in a way complain. Make it clear that you have made a mistake. You reflect. You bring people around you, and you try and prevent that really mistake from happening. We saw Ifat Zafar was very impressive with her Sahat Kahani. I think it means the story of health, doesn't it? And really the work they do is really very impressive. And also we learned from Abdul Hafiz, in a way, the recommendation of the APPS for improving quality of care in Pakistan is very welcome, but you need two for tango. You can't really make recommendations and produce guidelines unless the other side wants them. So, I mean, I've been working in international development for the last 9 years, and projects only succeed if the other side wants to work with you. So I think really this is, and it was heartening to learn that already you've got a response to what had been suggested. And well, I just told you about aches and pains, that's all. And you're all hungry. I think you've earned your lunch. But don't eat too much. Don't be affluent looking, as my mother said. Take care. Thank you very much.